Before community hospitals were closed, they provided a vital stepping stone on the route to recovery. In a community hospital, patients received round-the-clock clinical care and rehabilitation by trained nurses overseen by their own GP. Their medication was supervised. They were given the right pills at the right time. They were provided with services to aid recovery like physiotherapy. They were served nutritious meals. Their personal needs were met, clothes were washed, and bed linen was washed and changed. Patients could easily be visited by friends and relatives in their own community. These hospitals provided end-of-life care for the dying. Patients were only discharged from a community hospital when they were able to cope at home. Community hospitals have been replaced by a do-it-yourself system, where the patient in their own home is largely responsible for their own care. It is called care closer to home. Care close to home is a do-it-yourself healthcare system with no or limited medical care in any 24-hour period, no or limited supervision of medication, no or limited physiotherapy, no or limited nutritious meals, no or limited personal care, no or limited bed linen washed and changed, no or limited end-of-life care, no or limited freeing up of beds in the acute hospital. No choice of where to die. The elderly and vulnerable are left in relative isolation.
Angela, what has been your experience of care closer to home?
Quite difficult actually, because when I was discharged there was a bit of a crisis in the ward. I'd been in ICU for 5 days and then put into a general ward, and then they said you can go home now. And they didn't give me medication properly that whole day because there was a crisis, I don't know where. And when I was finally discharged, they just gave me paracetamol. I'd had major lung surgery and I'd been on morphine every few hours. And when I was discharged, I was in absolute agony. I was just rolling with pain and crying with pain. And they just said, here's some paracetamol, and then you can go home and you can organise your own care when you get home. And they gave me a stool to be washed on and a bed rest, and that was the care I had.
It's like as I said initially, it's almost like it's a constant cost-cutting exercise rather than looking at the quality of what is provided to someone. These are our most vulnerable people in our society who've contributed to society all their lives, and they deserve quality at the end of their lives. They deserve care and compassion, not how can we save money.
Well, I've only ever had one experience, and that was 3 years ago when I had my prostate removed in Exeter. What happened was it was a keyhole surgery, which means you've got 6 wounds, okay? So I had the operation, and they discharged me the very next day after giving me various bits of advice, giving me a box full of syringe hypodermics to inject myself with, and this sort of thing. Anyway, I got back home. It was a bit of a rough ride going back from Exeter to Barnstable. It was in my friend's brewery van, of all sort of things. Very uncomfortable. However, getting back home, went to bed. Next morning, I found, as the day went on, my wounds were bleeding because you get these decoagulants. So I tried to get referred into somebody to treat them, and it was very difficult. I ended up catching a taxi and going to the hospital in Barnstable.
They'd cut through my ribs and they'd done a 6-inch surgery on me, and I was just put on paracetamol, so you can imagine how much I was in pain. And then when I got home, I managed to get some morphine from the emergency doctors, that evening because I was in absolute agony. And she was very angry. She said, this is absolute nonsense that you've been you've been discharged today and nobody's taken any care for you. So she gave me some morphine, but then I didn't know how often to take it, and I was overdosing and having terrible side effects from it. And in the days ahead, even during the week, a week ahead, there'd been no aftercare at all. They just said, take your morphine, and I didn't know what else to do. And then I had another problem about the medication, so I was admitted to a hospital again because I had bad side effects from it. So all in all, it was quite a bad discharge for me.
I would feel myself, but living in Ilfracombe, which is a close community, that what the hospital provided was not only 24-hour care and nursing care to a high standard, and often end-of-life care, which is a very important thing. It also enabled the community to be involved in that person's care.
I could see the staff were under a lot of pressure because they were understaffed and they were discharging 7 people at the same time. So I could see it wasn't the staff's fault. It was definitely a lack of coordination. So I felt as if I'd been not taken care of at all.
Care closer to home, it feels like people are isolated and they have large periods of time without access to anybody coming in, and they are not cared for to the standard that you would expect in a hospital setting.
I was advised that I could go to a hospital closer to home. So I said, where is that? And they said, Honiton. I said, no, Honiton Hospital's just been closed in the last few days. And then they said, well, Exeter. I said, well, Exeter actually is quite a long way from where I live. It's at least half an hour with traffic. And I've got friends who've got no transport. So I would be isolated there. My family live away from Honiton except my son who works. And so it was quite a dilemma. I thought, well, I'd rather go home if they're going to set up all this care, which didn't happen. So that was my experience.
An awful lot of our clients are, they don't fit the profile of perhaps what care closer to home is pictured as through rose-tinted spectacles, perhaps. I think when we talk about care closer to home, in general terms, we picture perhaps someone being discharged from acute hospital back to their own home, which is possibly a bungalow on level ground, where they've got family and friends ready to help and support them and to enhance any formal nursing and social care package that's been put in place for them.
Yeah. It's very difficult to see from the healthcare plan from CHC what exactly is meant to be provided. I can stop them if you want. The hospice nurses at night, or the Marie Curie Macmillan nurses, were absolutely splendid. Sensible, would ring up and say, blah has happened, what do you think I should do? Or I'm new to the house, what do? I let the cats out or whatever. Splendid, sensible women, no complaint. The others had a lack of uniformity in the care, and the most worrying thing is they didn't actually supervise or ensure that Margaret took her medication. She had one of these blister packs 4 times a day. But the trouble is, if you've been alone all afternoon and want someone to talk to, somebody gives you the pills, so you put them to one side to have the conversation. Then, because you're a bit clumsy, you knock one of them on the floor, or the cat knocks one of them on the floor, or you don't take them for a bit. Sometimes I think they weren't taken at all. This, I think, is the absolute main failing. The fact that the medication is not being presented in a manner in which ensures she would take it is one of the main problems. Right. Otherwise, the standard of care was dodgy. I mean, if the sheets were soiled on one day, nobody had made the bed up with clean sheets. Nobody seemed to know whether this should be done or not. The care in a community hospital or in a nursing home is infinitely better.
So what would Margaret have done if she hadn't an advocate like yourself or a relative close by?
I don't know, to be perfectly honest. I mean, she was lucky in where she lived, in that there was a good community there, so there were plenty of visitors. I should imagine if you're more isolated or not naturally pleasant and liking to talk to people, you would run out of friends very, very quickly. But she was lucky in that there were people who would pass by and say, do you want a pint of milk, or just come upstairs to say hello or something.
Yeah.
Well, in my personal opinion, it's not working, because although district nurses and carers are working their utmost, there just isn't enough time to get around. And as far as community hospitals, they were there 24 hours a day for the patients that need overnight care.
Well, I shouldn't have thought it could be any worse than what it was. Right. It was absolutely diabolical. Yeah. Well, in the first instance, where, and this was in the early days actually, right, when they decided to operate. Yeah. She was operated on, and then even at that time they said, well, I think she can go home now. My wife said, I don't think I'm quite fit to go home. Don't feel good at all. Saw the GP. GP says, that's quite all right. You go into hospital for 3 weeks and you'll see how you feel. Right. And after the 3 weeks, everything was, well, pretty good really, how she was feeling. She could get up and walk from that hospital, right, out to the car, which she couldn't do before. They took her in a stretcher. So the treatment she had there was, well, second to none, I should think.
Yeah, that was 3 weeks in the community
hospital.
That
was 3 weeks in the community hospital. And what I'm saying about this hospital, it's not for the long-term patients, which I think some people thought made persons go in that hospital and stay for maybe months. This is not what we want. We just want a stepping stone between the hospital at Barnstable and the time that she comes home.
This is Torrington Hospital. This is where it all started. This is where the trial happened, and both Di and I worked in Torrington Hospital as staff nurses.
What services were provided in the hospital that isn't provided with care closer to home?
Well,
24-hour care.
Yes, I think that was the major thing. 24-hour care. You knew that when your loved one was in here, they were well looked after by NHS trained nurses.
Brian, the CCG are claiming that care closer to home was a success when it was launched in Torrington. Would you agree with this assessment?
No, I wouldn't, and I can say it with some conviction because I took part in the detailed scrutiny of what was actually happening and what was delivered in the Torrington area. I mean, the reality check of all this is that while care closer home, has got its merits, at the end of the day, unless it's properly resourced in terms of finance and people, then it can't deliver.
Claire, what are your main concerns about care closer to home?
Well, I think my main concern really is that whilst it sounds good in theory, it's not actually going to work in practice. And certainly in this area, we've got the Royal Devon Exeter Hospital, and that has had a long-standing problem with delayed discharges. So, and there are on any given day around between 60 and 80 people who are stuck in hospital beds that don't actually need to be there. And the clinical commissioning group says, well, the answer is to put more care in people's homes. Which sounds fine, but actually there aren't the carers to do that work. Nationally, around 15,000 beds have been cut since austerity started in 2010. In Eastern Devon alone, in 2012 we had around 250 community hospital beds, and that has now been cut to just 71. And the CCG has attempted to make a case for closing a very large numbers of beds right across Devon, or various CCGs have, and they just haven't done it. I mean, I'm a member of Devon County Council's Health and Adult Care Scrutiny Committee, and we have asked and asked and asked for the evidence to back up those decisions, and it just hasn't been forthcoming. Certainly the financial case has never been made. I'm completely convinced that there isn't a financial saving to be made. and already hearing that in some parts of Eastern Devon it's not working. People have demonstrated, they've signed petitions, they've attended the Health Scrutiny Committee meetings, they've done media interviews, campaign groups like yours, which are doing a fantastic job, are continuing to campaign. And I just think that it's a real shame that the government is continuing to underfund the NHS. It's not listening to people, it's not listening to the NHS itself, which is continually saying that it's unsustainable to cut the beds, to have this level of funding that we currently have. And I think that it's incumbent on all councillors of every single persuasion to take local people's concerns seriously. And from my perspective on Devon County Council's Health and Adult Care Scrutiny Committee, they're not doing that, and I think they're letting local people down.
Right.
Geoffrey Cox, Conservative MP for Torridge and West Devon, stated in a letter to a constituent, "I share your concern regarding the care closer to home model and have pointed out the illogicality of closing a purpose-built hospital because of shifting ideology in the NHS, while the new approach remains still not fully tested.